Welcome to today's episode of the Medical Fitness Podcast, powered by the Medicine-Rehab-Fitness Institute and the Medical Fitness Association. My name is Jeff Young, and I'm a kinesiologist and the co-founder of the Medicine, Rehab, and Fitness Institute. I'm co-hosting this episode with my friend and colleague, Thomas Hammett, Director of Operations at Pinnacle Lifestyle Medicine, and also a co-founder of the Medicine, Rehab, Fitness Institute.
Hello, everyone. We're excited to have Dr. Amy Bantham with us today on the show. Amy is the CEO and founder of Move to Live More and the immediate past president of the Physical Activity Alliance, the nation's largest coalition of organizations dedicated to promoting health and well-being through physical activity. Her work has included consulting, research, health and wellness coaching, personal training, group fitness, and much, much more. Amy, thank you so much for joining us, and welcome back to the podcast.
I am so delighted to be here with you. I met each of you through our shared interest in this idea of integrating healthcare and health and fitness. So I'm very excited to have this conversation with you.
Yeah, and we've only met one time before. I don't know if we've ever talked about this, but when you introduced yourself to me the first time, you mentioned that you were a doctor of public health that has spent several years researching clinician exercise referrals to community-based facilities. Sorry, I know that sounded robotic. I'm quoting, not my words, but I'm curious, what got you started down this road in the first place?
Well, I may have sounded robotic when I first sent it to you, but I was really trying to get some of your time to ask you some questions for some research I was doing. So I wanted to try to find what you were most passionate about. So you were willing to share your time, and I do appreciate that you were. So I started down this road. My goodness, I think it was possibly 2012 was the first research that I did on this. And it was when we were getting the URSA Foundation, so now the Health and Fitness Association Foundation, off the ground. And the foundation is focused on research and engagement and really helping health and fitness centers open their doors to people with chronic disease and disability. And we were partnering with the Harvard Institute of Lifestyle Medicine to do some research. And I think so Dr. Eddie Phillips, Dr. Rachel Pojednik, Dr. Mary Kennedy, and I were engaged and involved with a survey of clinicians, ACSM affiliated physicians, about their practices around talking with patients about physical activity and exercise, and then specifically their perspectives on referrals to community-based health clubs. And so I became engaged with that research. We ultimately published 2 papers in 2017 and 2018, I believe, based on that research. But that was what planted the seed. And when I went back to school full time in 2017 to get my Doctor of Public Health, I was doing field work in a couple areas. One was around bringing healthcare out into communities and around addressing unmet social needs. And then, of course, my longtime passion for exercise referrals as one of the options. And that was ultimately what I did for my doctoral thesis. I spent about 10 months working with a New England-based healthcare system and serving and interviewing their clinicians and their health coaches and their exercise professionals and their registered dietitians, and really trying to understand the barriers to exercise assessment, prescription, and referral, and why, I guess, the difference between comfort level and confidence in referring to a medical facility versus a commercial facility. So really got to dig deep on that difference and that trust gap between medical and commercial. And then I used that to launch my consulting firm, Move to Live More, which is focused on integrating healthcare, health and fitness, and community. So that's a little bit of the backstory. It started in 2012 and it continues very much today.
Yeah, that's incredible. And, I told you the first time we met that dissertation that you wrote on the New England health system is actually work that I use as a reference point. There's not much published that I've been able to find about health systems like that. And the internal referral pathways to fitness services or exercise that is structured. And it's such a good anchor point for anyone who hasn't read Amy's article. I would very much recommend doing so if you're in this space because of how valuable it's been to me. So thank you for sharing all that.
Thank you for that. And it is 100 pages, and that's my caveat. I will say Dr. Pajednik and Dr. Kennedy have strongly, strongly encouraged me to get those papers published. So instead of citing my dissertation, they can actually cite peer-reviewed literature. So that is the plan for this summer. I'm committing to it on air. I have drafts of 2 papers, and they're going out this summer. So people who don't want to read 100 pages can read 2 peer-reviewed articles.
You might, I actually have maybe a little bit of an off-topic question, but it's something I've never asked you and I'm curious about. Back several years ago when I was chairing the American College of Lifestyle Medicine's Fitness and Medicine MIG, and because the American Council on Exercise is one of their strategic partners, I was fortunate to be able to have a bunch of candid conversations with Cedric Bryant, who I think now he was the president and chief science officer, but I believe now he's the CEO, right, of the American Council on Exercise. And so I know through some candid conversations with him a little bit of the backstory of how the Physical Activity Alliance got involved. And I'm totally paraphrasing, I might even be wrong here, but basically it was the merging of 3 organizations that kind of had the same vision, right? And my understanding, and this is going to lead to my question to you, is that there was basically kind of like a discussion amongst all 3, basically saying, hey, we have the same vision, and so why not join forces, etc. So I'm curious, is that accurate? And also, now that I'm hearing more about your history, did you play a role in that? And did you get involved with the PAA right from the start like that, or did you come in a little bit later? I'm very curious about the history with that.
Yeah, so it is accurate. And yes, I was engaged through one of the predecessor organizations, the National Coalition for Promoting Physical Activity. During my time at IRSA, the Health and Fitness Association, I was engaged through the work of the public policy team led by Helen Durkin, Tom Richards, myself. We were engaged with the NCPPA. And I actually have a podcast with Dr. Lori Witzel where we talk about how these 3 organizations came together, recognizing the importance of speaking with a unified collective voice about promoting health and well-being through physical activity. So yes, I was engaged with NCPPA, less engaged when I was getting my doctorate, a little bit engaged. I was still consulting to IRSA, have been since 2017, but really love the fact that the 3 organizations came together. The Physical Activity Alliance just celebrated our 4th birthday. And really, so still in its, I guess I say, toddler phase, and really thinking through, and I'm very much focused on establishing processes and the behind the scenes. It was a really exciting time to be the 3rd president of the Physical Activity Alliance and take over the reins from Graham Melstrom, formerly with ACE, and he was preceded by Monty Ward with ACSM. And the ability, what I love, there are a couple things I loved just personally about being involved with the Physical Activity Alliance. One is, as someone who is starting my own woman-owned small business, joining as a board organization, it really allowed me to be engaged at a very high level with policy and systems change in ways that I couldn't just working as a small business, working with individual clients. I loved that piece of it. I also loved that it was essentially taking what I did for my doctoral thesis At a micro level. I spent 10 months evaluating an exercise referral network at one healthcare system. And the work that we do with Physical Activity Alliance and our It's Time to Move initiative really works to make assessment, prescription, and referral of physical activity a standard of care in the US healthcare system. So we are working to develop standardized clinical measures and that exact language that would prompt not a subset of clinicians, but every clinician to have a conversation with every patient about their minutes per day, days per week of aerobic physical activity and their days per week of strength training. And we developed that language. I was a part of the working group that developed that language, that was involved in the multi-year process, the HL7 accreditation process, to develop that language, to develop that implementation guide, to get that through this very rigorous process, and to go down a path where I recognized when I was working with that one health system that had a referral system in place for 10 years, and talking with clinicians who had absolutely no idea that it existed, and talking with exercise professionals who saw having access to the electronic health record system as critical to their success
Critical.
with providing the best patient care to help their clients, members, patients achieve their best health outcomes. So I saw that electronic health, it's not the be all end all, but it is very important. And so the ability to take that knowledge and take that research and understanding the barriers and to try to overcome those barriers, and seeing the ability to get the physical activity data element in every single electronic health record system, which is what we were able to do with the PAA It's Time to Move campaign by 2025. In order to be certified as a EHR in the United States, they will have to have that physical activity vital sign, that exercise vital sign, as a field in the electronic health record. So the ability to take it from just one health system to have that as part of all EHRs was really exciting. And to be able to do that in essentially, so I did my research in 2019, and by 2025 it will be in every EHR. So
That's ridiculous.
that was exciting.
Yeah, and let me just interject real quick before because I'm curious what Thomas thinks about all this stuff. But I asked this question partially because or actually mainly because I'm a huge fan of history, and I just want the listeners. I just think it's important. I think history is important, especially when something were involved with as you just said, the genesis of something and played major role in this stuff. So I just I asked that question because A, I was curious, and B, there's a major movement going on that a lot of people don't know about, and I want them to A, know about it, and B, the history behind it, and we should never forget the history. And then my only other last comment is, in 10 years, I'm in New York City, and for 10 years, I worked in the Mount Sinai system. And in my almost 30-year career, that was the only 10 years that I ever experienced having access to the EHR. But I have personal experience with it now, and absolutely, I couldn't believe it. The difference it made in me kind of like getting to know the patient before I even saw them, just seeing them on my schedule that I'm getting ready to do a consult with them later that day or the next day, and being able to go into that and see the notes and their history and what almost like whatever I wanted to look at, and what a big deal that was for me with just like the overall picture, and then ultimately programming.
Yeah, I actually was able to talk with health coaches, RDs, and exercise professionals about their perspectives of how important it was, because at the time, the health system that I was evaluating was going through an EHR upgrade. And the exercise professionals were fighting, they were advocating for themselves to be included as one of the entities that did have access. And if you're thinking about a collaborative care team and 2/3 of it don't have access to the EHR, it is inhibiting, and what type of message does it send? And they really saw it as critical to their success. So I was very excited. There's been so much work that has gone into the PAA's efforts to include this physical activity data element as part of the EHR. I've been involved in a very small piece of it. It is a huge effort by a huge number of much smarter people than I in this area, but I love the fact that I was able to help to identify a problem, and then instead of just sort of floundering in the problem or getting stymied by the problem, to really look forward toward a solution. And granted, just having a field is not enough of a solution. So now we're turning toward, and I'm involved with the implementation working group, where we're actually focused on essentially field testing it and seeing how, if it's not part of the clinical workflow, it won't be utilized. So seeing how to test it and make sure it's part of the clinical workflow. And I just learned that as part of this field test, there will be an app that will help those with health systems who are accessing it and implementing it to be able to implement it as easily as possible. Again, trying to remove barriers. We've got to remove barriers, or it's not going to become part of the workflow.
Yeah, I just have to say, based on like, it's really incredible that you've done this work. I know that feels like a small change to implement a field, which, for anyone who doesn't understand the EHR, what the workflow would be, it isn't like this situation is now physicians have to ask the question, but they're given a place to put this information in their note, where previously there was no field for putting it in. They could put it in a free body of a note, for example, but they'd have to prompt themselves to do it. It's like the art of the behavioral nudge, right? And I'm sure you've done a lot of behavioral research kind of stuff, and I'm a freakonomics guy, so I love this kind of thing. It's a small change, but it makes a big difference for them to not have to think of the question, think of the place to put it, think of the prompt on their own. Individually in health systems across America, there's going to be a place to do this, and that's just a really cool small change that's going to make a big difference.
Yeah, I interviewed both Dr. Bob Salas and Dr. Liz Joy for my podcast, and they talked about the importance of having these prompts. And I even think Dr. Joy talked about, and I was lucky enough to work at Intermountain Healthcare for a summer with Dr. Joy. She talked about how not only is there a field and the medical assistant will assess physical activity levels, but then there's a field where I believe it flashes red if the patient isn't meeting physical activity guidelines, which of course prompts that conversation about physical activity, because you can't, the conversation is the first step. And then of course there's connecting the patient to resources to support them in their follow through on behavior change. So it sounds like we're all very fascinated by behavior change. And that was one aspect of my doctoral thesis that I really focused on. It's not just patient behavior change. Of course, we're trying to support behavior change around physical activity, but it's clinician behavior change as well, to support them in having those conversations. And the EHR is an important tool to support that clinician behavior change.
Yeah, that's great. So you've done some great work on getting health systems and clinicians some tools. The last time we spoke, you were doing some, which doesn't sound new, by the way, you were doing some investigation on what makes a fitness program trustworthy and valuable in the eyes of clinicians, particularly on behalf of a commercial fitness organization. I'm curious what you've learned most recently from this research.
Yeah, and this is something I've been interested in from, as you heard, from my very beginnings when I was working with the Health and Fitness Association Foundation on this research. Not only is it about what happens in the clinician's office, but it's about the type of resources that they connect them to. And from my research in 2019, Not surprisingly, this is not a surprise to you. It's not a surprise to any of your listeners. Clinicians are much more comfortable referring to a hospital-affiliated medical fitness center than they are to a commercial health and fitness center. So at the time, there were a couple deliverables that came out of my doctoral thesis. One of them was a 10-step roadmap for healthcare systems for how to facilitate and support these conversations between clinician and patient and these referrals. And then I also had a 10-step roadmap specifically targeted toward commercial health and fitness centers, saying these are the 10 things you can do to become more trusted, maybe as trusted as this default, this bias that the clinicians have to a medical fitness facility. This is how you can become more trusted. And so a lot of it was around clinicians are much more likely to refer to what they understand, what they know. Thus, the importance of credentialing and education on the part of the fitness professionals who are receiving the referral, the personal familiarity. So again, clinicians who are physically active themselves, who are physically active in maybe a commercial-based health and fitness facility, invite them in, help them understand who you are, what you offer, what's your equipment, what's your infrastructure, what is your credentialing pathway. I had clinicians say to me, I don't understand this world of certifications that the fitness professionals have. What I want to know that they have the knowledge, the expertise, that they specifically have the knowledge and expertise working with the populations that I am sending their way. And so that was a really important piece. And then there were the soft skills. I want to know that they are empathetic. I want to know that they do not have weight bias or stigma if I'm sending them patients with obesity. And so a lot of what I learned in 2019 was confirmed when I did this research over the last 6 months for this global health and fitness chain that I have been helping by essentially updating my research. I spoke with clinicians, I spoke with studio operators, and I really tried to understand their perspectives on this particular health and fitness chain, their knowledge of it, their familiarity with it, what they're hearing from patients and colleagues, and really tried to understand, okay, what would build your trust and credibility. So I learned a lot about what type of information they want to receive back from their patient. So I developed a whole success toolkit that we could put in the hands of providers so they could make those exercise referrals. We put together a toolkit that we could put in the hands of studio owners and staff so they could have those conversations with providers who were members of the facility. And we put together materials for consumers so they could have that conversation with their provider, maybe who sent them there in the first place, or maybe who didn't send them there, but would be very interested in their level of adherence to an exercise program, their progression through the exercise program, their level of engagement. That was one thing that was really surprising about the research. We think providers want a lot more data and information than they actually do. And Dr. Bob Salas had said this to me years ago when I interviewed him for my podcast. He was like, Amy, I don't want to know how many squats they're doing. I want to know essentially, are they going? Are they progressing? And so the templates that we put together which supports the patient and reporting back to the clinician are very much focused on uptake, adherence, progression, engagement. And that really opens the channels of communication. Because I had clinicians say to me, I have never, ever gotten any type of progress report from a patient who went to a commercial facility. And I said, we are going to change that. So we have a field test going. It's been in place for almost a month now. We have a number of materials that we're constantly improving and updating. And we're working on really making sure that we have what we need in place to help make this, to really open the channels of communication through the patient, through the member, between the facility and the exercise professional.
That's at least like while you're saying all this, can't. So my question to you is, um, how is this going to be disseminated on a large scale? Like how, when, like what's, to the best of what you can answer right now, what's the game plan being set in place? Because this is game changer, and I would love to know what the game plan is here.
Yeah, and we are what did they say? We're building the bridge as we cross it. We are in the
Yeah.
throes of it. We're about maybe a month and a half into the field test, and I'm very much about constant improvement, constant and continuous improvement. And what I'm hearing more and more is these tools are great and we want more. And so, how do we add it and how do we streamline it? And ultimately, the goal, this is a global fitness chain, the goal is to scale it. And so, really streamline and scale. And our hope is to present this at ACSM 2025
Cool. Good.
and really share the process and the outcomes to date. So we're a little bit early in the process, but it is exciting. It's a very exciting time, and the fact that we're able to. My favorite part of it is we talk about this a lot, but the ability to do it and to get this constant feedback, this is what we're hearing from providers. This is what we're hearing from consumers. This is what we're hearing from studios. And then to make tweaks so every conversation is easier, so every provider sees more value in the resources and tools, because it has to be. I joke because when I sit on panels and talk about this work, I'm sort of the barriers person, and they usually have me go first because who wants to sort of end with barriers? But my research in 2019 was very much on barriers. It was the time, tools, training, technology, cost. I had Mike Stack recommended that instead of cost, I say treasure because I was looking for a T for cost, and trust as barriers to clinicians having those conversations, prescribing movement, and referring patients to really a community or medical facility that would best meet the needs of the patient, and how to overcome all those barriers to get to solutions. So I love the fact that I'm able to take all that knowledge about barriers and focus on solutions and real-time solutions, and to get real-time feedback from all the different audiences that we're targeting about what would make this something that they were most likely. Again, to our point, it has to be part of the clinical workflow. It has to be part of the conversations that studios are having with their prospective members.
One of the things that you mentioned that really stood out to me, because it's been a question that I've had for a long time on the, like, how much do clinicians really care? And it's around that, the credentialing of the fitness professional. And I really I've wondered how much does that play into this whole thing? And there's a movement right now going on around this idea of the qualified healthcare professional, QHP, for fitness professionals in particular, to make a more standardized definition around what a fitness professional should look like to see medical patients, essentially, or to receive those medical referrals. And I'm curious, I don't know if there's a way that you can quantify or explain how important that's felt, the credentialing side of this. Like, if my fitness professional I'm referring to has ACSM certification versus no certification versus the weekend course, like, how much do clinicians really care about that? And then, on the other side of that, what's the promise of this QHP to help with that issue?
They care that they're qualified. They don't care about ACSM versus ACE versus, because they don't have the time to explore and understand what one versus another. So I think it behooves us, and I spend a lot of time talking about the professionalization of exercise professionals and working to define in a very standardized way what a qualified health and fitness professional is, so that we are addressing the piece that the providers do care about, which is the qualification, without devolving into this credential versus that credential versus that credential. And I think I talked a little bit about this. They care about the expertise with specific populations. They care very much about that. They care about like things like motivational interviewing skills, active listening, empathy, like those, a little bit of those soft skills, but really the extent to which, and I had one clinician say this, I want to know that they're going to help my patient get better and not get hurt, essentially. And so I think much as what we're doing with It's Time to Move with PAA in terms of standardizing that physical activity data element, I think there is a standardization of what a qualified health and fitness professional is. And we've even used some language around what a qualified health and fitness professional is in the implementation guide that we've put together in our field testing. And it does come down to third-party accredited certifications. Not a whole discussion around one versus another, but a rigorous process by which the certifications become third-party accredited.
Love it. I could talk about this. Like, the three of us just live in the same world. It's crazy. So I know that all of us could probably just go on for hours about this, but I'm going to switch gears and ask you a question related to an article that you and I co-authored. But before I ask you the question, just because this is going to be fun for me to say, even if it hopefully won't embarrass you or anything, but the primary reason why the three of us are here talking is because you played a primary role in this podcast even launching. And you've heard me say this before. I want our audience to know that originally there was never an intention for there to be a medical fitness podcast. And as you know, I reached out to you through LinkedIn, and we got some conversations, and we met. And next thing you know, we're having a recorded show, which was going to be for something else. And I won't get into the details, but next thing you know, I'm realizing, uh-oh, guess what? We just started a podcast. And then I reached out to Thomas, and I said, guess what? I just had Dr. Amy Bantham on, and we need to start a podcast. And that's literally how this whole thing started. And now here we are, collaborating with the Medical Fitness Association with it. So it's just really cool for me that here we are talking again and talking about things that we could talk about for hours. And it all started because Dr. Amy Bantham, launched this without even the intention of launching it. So
the Medical Fitness Podcast is brought to you in part by the Medical Fitness Association. If you'd like to hear more from Dr. Amy Bantham, she'll be presenting at the Medical Fitness Association's annual conference this November 19 through 21 in New Orleans. Don't miss this great opportunity to hear from and network with leaders in the medical fitness industry. For more information about the Medical Fitness Association's annual conference and to register, visit medicalfitness.org. That's medicalfitness.org.
Well, I think let's give credit where credit is due. You reached out and said you'd read my dissertation. Not many people, my mom, my dad, my committee, then Thomas. And so that was, and of course, I do think there's an important space to have people talking about the work that's being done. And that's why I have a friend and colleague who started his own business years and years ago. Actually, he was a school classmate, and he really encouraged me to start a podcast. And ways to me, it's my way to live my mission.
Yes.
by who I have on the show and what we talk about.
Yes.
And so I have thought leaders working to integrate healthcare and health and fitness. And then I add in another sector, add in the community sector. So I do have a lot of community-based organizations who are working to get people moving, not in facilities, but in necessarily sometimes in facilities, but in community-based facilities or in parks or in churches or in parking lots or in schoolyards. And so that was really important to me to build a community of thought leaders, really addressing inactivity by connecting those sectors. So I think it's fabulous that you started a podcast. I'm honored to have been a part of it.
Yeah. No, now here we are and relating to what you just said, and we get to do something similar. So thank you for that. But let me jump into next question, which again, I was, ridiculously fortunate to have co-authored a paper with you and Dr. Matthew Campert from the Cleveland Clinic, which is going to be, or maybe by the time people are listening to this particular episode, it will have already been published as part of a special issue of the American College of Sports Medicine's Health and Fitness Journal, August 2024. The issue itself is titled Advocacy and Professionalization Within the Exercise Profession, which we've been talking about. But in the article that myself and Matthew co-authored, we talked about some of the things clinicians are seeking from fitness programs and professionals once the referral has been made. So can you speak in more detail about this from both your experience and your own personal perspective?
Yeah, and I think we talked about this a little bit with what Dr. Sala said. Like, I don't want to know how many squats they're doing. And I do think this came out with the research that Thomas, you were kind enough to chat with me about. Really, they wanted to understand uptake. So did they follow through once? Adherence, did they follow through over time? Engagement, were they engaged over time? Were they having fun? We think that clinicians really want to get down in the nitty gritty. I can't tell you how many clinicians told me, I want to know if they're having fun, if they're engaged. Is this becoming a part of their life, something that they do every day instead of really what we think about with the prescription? A prescription does not sound fun, right? And so it's a referral to an evidence-based program that supports the uptake, adherence, progression, engagement, or to a qualified health and fitness professional. I think we've talked about the professionalization of health and fitness, the health and fitness sector generally, and what that looks like. So they're looking to get that type of information back. And then, of course, yes, there is interest in the health outcomes. And I think we covered this a little bit, and that's the
Yeah.
benefit of having had a clinician involved saying, well, I don't necessarily need to get back all of that blood work, right? I don't, because I can do that in the clinic. It's what I can't do that it's almost the color commentary. I talk about, I'm a mixed methods researcher, so I do both quantitative and qualitative research. And so to me, the quantitative is the black and white, and the qualitative is the wonderful color that fills out the complete picture. So I think yes, they want to get the quantitative in terms of really is this becoming something that they do 2 to 3 times a week to help them meet the guidelines. That was another thing that was a real aha moment to me. They wanted to know, are my inactive and insufficiently active patients, are we moving them along the continuum toward meeting physical activity guidelines? Are they meeting physical activity guidelines?
Mm.
Yes or no? And again, since it's not a black and white question, where are they falling? We're getting a lot of bang for the buck of getting inactive to insufficiently active. Can we push them along even more to get them to meet those guidelines?
Yeah. Go ahead, Thomas.
I'm just really curious because I think that may not sound like a challenging thing for fitness professionals or fitness groups to do, is to show the client that you referred to me or the patient you referred to me is getting their ACSM recommended exercise.
Yeah.
It may not seem like that's hard, but it's not happening. And I'm
Oh,
curious maybe why, if you could explain why, and I'll even share some background of my own after I give you a chance to speak, because I have my own anecdotal experience, but I'd love to hear what you found as to why this isn't just happening.
why it's not being communicated back.
Yeah, like why it's not as easy as, oh, the fitness professional just needs to tell the referring clinician that the patient or the referred person is getting their exercise that we plan for them to get.
And yeah,
Yeah.
and we focus a lot on empowering the patient to be that advocate for themselves and supporting them with tools so they can report back. That was what was so surprising to me about my original research in 2019. We almost had this closed loop system where they were all working within a healthcare system, and they still didn't know. About a third of them really, they didn't know if the patient was following through. And it's like, but why don't you know? And so empowering the clinician to use the tools that they have at their disposal to know, empowering the patient to report back, to be that ambassador, because clinicians say there's a lot of value to hearing from my patient. Yeah, I've been doing this and I'm kind of enjoying it and I feel stronger. And oh, by the way, I'm doing it a couple times a week. And so then they can really calculate and figure out, oh, 2 days a week, muscle strengthening, great. Okay, they're getting that 150 minutes, great. Um, and so really empowering each party. So I went through providers, empowering the consumer, the patient, the member, and then also empowering the fitness professional to arm and equip that consumer with the information and encouraging them to report back to the clinician that they, again, if they're following through and they're engaged and they're having fun and they're seeing the changes in themselves, and they're prompted by a clinician who's prompted by the EHR. Ah, last time you came in, you mentioned that you were getting about 20 minutes a week of physical activity. How is that going? Oh, I started this walking program and I'm really enjoying it. Or, oh, I've been doing this band strength training class with my church group. Or you can fill in the blank, but the ability for them to be prompted to have that conversation, then to have an engaged consumer. We always laugh because when I sit on panels, is it a patient? Is it a member? Is it a client? Who is it? It's the person that's having the conversation with the provider, and the ability to really provide that color commentary and fill in. So yeah,
Yeah.
I'd love to hear more, Thomas, about what you're seeing and hearing.
Well, I would completely agree with you that the subjective feedback from people that are really participating it's typically pretty easy to get, right? People that are really engaged with their exercise program, they'll tell you, right? Like they'll tell you the changes they're making, they'll tell you what they're feeling, they'll tell you how fun they're having interacting with people. It's the objective side of seeing that behavior change that's actually really, to me, it's hard without some kind of technology integration. The power of wearables, or you know Jeff started this question with talking about Dr. Matthew Campert, and he and I are both fans of using a wellness cloud system through Technogym to track workouts and give objective feedbacks, things that a patient could pull up an app with their physician and show them how much they've been exercising. The objective side of that is missing a lot of the time, because we either don't track our exercise or write it on paper and the paper gets lost or it's gone or whatever, right? We just don't track it. And the new technology enabling us to see the behavior happen and track it and kind of prove it is a really cool piece of feedback that I think I really hope starts to be part of this clinician feedback loop, that they can see the objective change in the behavior. The subjective side obviously is the most important part. You love having happy clients, but when you can see the objective change too, I think it's just another really good reinforcer.
Yeah, two comments on that. One thing, recognizing how important that was, the Physical Activity Alliance, it's time to move. We used language in the implementation guide that really acknowledged where we are currently, that much of it is self-report, while also not limiting and opening up ourselves up to a world in the future where we are better positioned to take advantage of wearable data. And the global fitness chain that I'm working with, to me, one of their greatest assets and advantages is the extent to which they capture just a wonderful, robust data set. And so that will be very much a piece of the work that we continue to do together.
I will add to this before moving on to the next question is, as I listen to both of you talk, what goes on in my mind, it was my 10 years in this major hospital system in New York City that was a closed loop system like you're describing. And on paper, we were integrative and all that stuff. But the truth is we were very disconnected and what we would have benefited so much from both of you coming into our system and overhauling it based on all the things that you were just talking about. And another thing that came to mind as you were talking was my collaboration with Jeff Duran, who's the chair of the board of directors of the Medical Fitness Association. And we did a lot of work and a lot of many Zoom meetings and talking about barriers and you know we've been revolving much of this podcast around barriers and one of the things we talked about was the importance of, and I think that everything you've been discussing has been alluding to this, you have to have it built into the system somehow. So my first job out of college was at Duke University Medical Center's Diet and Fitness Center. This is back in the late 90s, but arguably one of the leading medical weight loss facilities at the time, and had medicine, rehab, fitness, and I'm sorry, medicine, nutrition, fitness, and behavior components. And we truly did integrate, and it was a closed loop system, but we all communicated with each other. And so part of my point is that I've been on both sides of the fence, so I know what it's like to work in healthcare systems and institutions that do things right and also that don't do things as well. And that's definitely part of what fuels my passion. So that's what was going through my mind as I was hearing you talk. But it actually leads to, again, we've been talking a lot about barriers, but I would be remiss if I don't at least ask one more question because I'm just really curious about your thoughts on this. And that is, I like to view my bias is that I view barriers. I don't like the word barrier without using the word perceived in front of it. The
Mhm.
barriers are perceived barriers. And that's part of it's just my pet peeve in general, is that just generally speaking, when people talk about barriers and across the board, whether it's fitness professionals talking about a barrier with their client or it's a clinician talking about a barrier with their patient, that they seem to view this in the sense that, oh, this is a barrier. I can't do anything about it. And yet our worlds revolve around, no, these are perceived barriers. And there's solutions to them. And one quick anecdote before I get your view on this is that, for example, I've had many conversations with uh, primary care providers, for example, where they'll talk about that my patient doesn't want to exercise. My patient doesn't want to do the lifestyle changes, things like that. And what I'll be thinking in my mind, and I can say this comfortably with both of you, is that you're actually telling me a little bit about your skill set when you say that, because and you actually alluded to this earlier. The, the client or the patient needs the changes. So do you, and maybe we need to talk to you about your skill set with motivational interviewing and talking to your patients about those hard questions that sometimes we need to ask them and move on from there. So, with all that said, I'm curious what your response to that is.
Yeah, I agree with you 100%, which is why when I heard the barriers, each one I tried to think through and find a solution to. So time, the clinician doesn't have enough time to have the conversation. Okay, I think I mentioned Dr. Joy with Intermountain, with the medical assistant, have it beginning the conversation, assessing, inputting the physical activity levels, which prompts a conversation with that flashing red light. So what does that shave off? 5-10 minutes, and it helps physical activity bubble up as part of that 15-minute visit. So, and then in terms of tools and technology, I think that we have talked through the electronic health record, not as the be all end all, but as an important tool for addressing the tool technology barrier. And I think we're starting to move that dial. The training, the fact that clinicians get 1 hour, 8 hours of training in physical activity, exercise in medical school and continuing education. There are great efforts. There are legislative efforts to address that. There are programmatic efforts to address that. So I do see that dial moving as well. The cost, I think every conversation that we have about really the referral to a qualified health and fitness professional, professionalizing the sector, that is all moving us down a path toward a collaborative care team that has the tools to talk to each other, and not just the registered dietitian is reimbursed for their time, but other members of the collaborative care team are reimbursed for their time. So there's a whole payer strategy and a reimbursement strategy around this that I think we're in the early stages of, but it has to be part of the solution. And then trust. I think I spend a lot of time, you don't build trust overnight, you build trust over time. It's about establishing credibility. It's about establishing personal relationships. It's about having success and reporting success of working with patients. To me, it's not getting clinicians to refer a patient one-off. It's about them believing and trusting and getting back the information and seeing the improvements. So they're referring not one, but all their patients who they see would benefit and improve and improve their health and reap the benefits from. So I think hopefully I tried to sort of parse out each. I hear you. In my research, it was so frustrating to me that when I asked, why don't you talk with your patients about movement or refer them to a community-based facility or a medical facility? And the response was, because I don't think they'll follow through. To me, that is a self-fulfilling prophecy. If you don't give them the chance and the guidelines and the information and the guardrails and the support to follow through, if you just immediately assume that they're not going to, so you don't even talk about it, that is not doing anyone a service.
And it's so common.
Yes. We want to set them up for success, and we want to set them up for their best optimal mental health, physical health outcomes. That's our number one goal.
Absolutely.
Yeah. Well, thanks so much for sharing that, Amy. I think based on time, we'll probably wrap up here after just another short question, but I'm curious, how can people connect with you or learn more about the work you're doing? When are you going to get us those 10-step guides you were talking about, all that kind of stuff? What can we share with the people that are listening?
Yeah, of course. So listeners can find me at movetolivemore.com. That is my main website, which talks about who I am and the type of services I provide to the type of clients that I provide. I have my podcast, movetolivemore.com/podcast. I have my newsletter, movetolivemore.com/newsletter, where people can sign up and hear from me monthly about the work that I'm doing. a lot around exactly what we talked about today goes in the newsletter. And then I wrote a book, which is a little bit different than what we talked about, but getting our youngest members of our population moving, book, which is a guide for parents, caregivers, coaches, teachers, fitness professionals about how to get kids moving. And that's at movetolivemore.com/book. And
Title
then
of the book, the book title?
Move to Live More.
Oh,
I'm very consistent. I spent a lot of time thinking about Move to Live More. I trademarked it, and to me, it's about movement for a better, longer life. So it's quality of life, longevity. And then anyone who wants to reach out to me, I'm very active on LinkedIn. Amy Bantham, also Move to Live More, active on X, Twitter at Move to Live More, Instagram at Move to Live More. So very consistent, very consistent with Move to Live More.
Yeah, thanks for staying consistent for all of us. Man, well, thank you so much for sharing about your book. I honestly, I certainly don't think our listeners would be tired of hearing from you. And I feel like that's a whole additional podcast in and of itself. It's something we've talked to Rick Howard about with regards to getting youth more physically active, and even just what happens in our primary schooling system that may get in the way of people being more physically active at a young age and having positive connotations with exercise and physical activity. And I have to really restrain myself from going down a full additional podcast starting right now. We'd love to have you back. That's just my plug for getting you back here next time. And really, thank you so much for the conversation today. It's been a pleasure. I know tremendously valuable information that you're still gaining and sharing with us, and really thankful you could share that with our listeners too.
Oh,
thank you so much.
I love chatting with both of you. You're both doing such important work in this field. So it's such a pleasure. Thank you for hosting me.
Thank you.
This episode of the Medical Fitness Podcast is brought to you by the Medicine-Rehab-Fitness Institute. The MRFI has been co-founded by medical, rehab, and fitness practitioners who see the medical necessity in getting people to be more active and fit. There is a sleeping giant of opportunity to building a more active population, an opportunity which lies in a more effective medical referral pathway to exercise programs and professionals equipped to serve that pathway. To learn more about our services and how we're working to make this a reality, visit mrfinstitute.org. That's mrfinstitute.org.